Dr. Carl Orringer is the director of the Preventive Cardiovascular Medicine program at the University of Miami Health System. He's an associate professor of clinical medicine and director of the Preventive Cardiovascular Medicine program. He is a past president of the National Lipid Association, and he's been involved on the writing committees of some of the most important consensus decisions and guidelines on, for example, management of blood cholesterol. It's 12 o'clock right now. We have him until 1 o'clock. He's going to present on kind of the latest thinking on a lot of preventive cardiology issues. We have him until 1 o'clock, so he'll present and we'll have plenty of time for questions, and then we will go to lunch after that. So I'll turn it over to Dr. Orringer. Thank you.
Well, I hope you can all hear me. It's really a great pleasure to have you here today, University of Miami, and we're excited to open this whole area of preventive cardiology up to you. There's lots going on in the field, lots of things that your readers are going to be interested in, and lots of things that you will be interested in for your own health. So without further ado, let's proceed ahead. I have no disclosures. So there are many things to consider in preventive cardiovascular medicine. We're going to talk a little bit about primary versus secondary prevention, making sure you understand the difference. Assessment of risk in primary prevention, diet and exercise counseling, smoking cessation, blood pressure management, lipid management, diabetes drugs that reduce cardiovascular disease risk, when to consider aspirin, and new drugs for prevention that are in development. Now, any of these could be a 1-hour talk in and of themselves, but I'm going to kind of try to give you an overview of the whole topic, and I think that you're going to find this interesting and stimulating. Certainly your readers want to know about it, and you will undoubtedly think of questions that you want to direct to me. Well, Dr. Goff was instrumental in developing this risk calculator with the Risk Assessment Working Group when the 2013 cholesterol guideline was produced. But this is how most doctors tend to use it. They have here we go, it's hard to see against the white background, but on our smartphones, we put in various values. We put in things like, what is the patient's sex? What is the patient's HDL cholesterol, total cholesterol? Are they hypertensive? What is their, yes?
Sorry to interrupt. Could you please pick up the microphone a little bit higher?
Let's see if it's working. Is it working?
No, it's not.
Not working?
Thank you.
Is it working now or not?
I'll check right in.
Okay. So, you'll let me know if it works for the group. At any rate, so total cholesterol, HDL cholesterol, blood pressure, are they smokers, are they diabetics? And a number comes up here for 10-year risk for the development of fatal or non-fatal myocardial infarction or fatal or non-fatal stroke. And when that number exceeds 7.5, those patients are felt to have a high enough risk that they might merit consideration of drug therapy for prevention. So this is the risk calculator that's used. But the risk calculator is also used to help us to decide when do we use drug therapy to treat hypertension. So it's a very important tool that was developed along with the 2013 cholesterol guideline. Now, a lot of the information I'm going to give you emanates from this paper, which is the 2019 ACC-AHA guideline on the primary prevention of cardiovascular disease. But some of it is going to be more than this because there have been things that have happened since the publication of this document. So I really want you to be up to date with everything in our field. So some key take-home messages from that document. One is that the most important way to prevent atherosclerotic vascular disease, heart failure, or atrial fibrillation is to promote a healthy lifestyle for the patient's life. And that seems to make sense intrinsically, but many people forget that in our focus on drug therapy. And there are clearly evidence-based studies to show that the regular consumption of vegetables, fruits, whole grains, legumes, low-fat dairy products, low-fat poultry without skin, fish, seafood, non-tropical oils, and limited intake of sugary beverages, sweets, red meat, and then caloric intake that's appropriate for the amount that you utilize. That's the way that you generally reduce cardiovascular risk. But your readers and some of you are probably going to say, but what about the keto diet? That's something I've heard a lot about. I want to know if that really makes sense. And there was an interesting, really a nice review done by Carol Kirkpatrick and several of her colleagues of the National Lipid Association, really looking at these low and very low carbohydrate diets, including the keto diet. And the review indicated, after a careful analysis of the data, that keto diets or low-carb diets are not superior to other dietary approaches. They may have certain advantages with regard to appetite control. They lower triglycerides. They may help to slightly reduce the need for some type 2 diabetes medications. But some patients who follow these diets actually have a marked increase in their LDL cholesterol. So that's also a concern. I've certainly seen that in a number of my patients referred in for lipid disorders. And there's no clear evidence that there's an improvement in either blood pressure or inflammatory markers that promote atherosclerosis. And there are minimal data on long-term safety. So again, if people decide to do this, that's up to them. But we're not encouraging this as a general approach to reducing cardiovascular risk. What about those who say, what about intermittent fasting? You know, and again, this is an interesting and popular topic. There was an interesting review done in the New England Journal of Medicine just recently on this particular topic. And this intermittent fasting business usually entails 6 to 10 hour feeding periods, 5 to 7 days a week. And then 2 days a week, people consume 500 to 1,000 calories. And there have been a few preclinical studies that suggest maybe there's some benefit for treatment of obesity or diabetes. Maybe there are some preventive benefits.
What do you mean by preclinical? Does it mean rats?
Yeah, well, no, it means certain studies in rats and also in certain studies in very small groups of human subjects. So there are very little solid data at this point on it. But there are some interesting scientific studies which you should certainly look at in this article in the New England Journal of Medicine. So there may be some benefits, but there are limitations. And the limitations are, first of all, consuming multiple meals a day is kind of ingrained in our culture. We're used to doing it, and there's an abundance of food around, so it's kind of easy to eat. Secondly, when you switch to intermittent fasting, one of the problems is that people tend to become hungry, irritable, and have reduced ability to concentrate, at least for a month. So that's something that people have difficulty getting through unless they are highly committed to it. And then third, of course, physicians or other healthcare professionals are not really well-versed in trying to instruct their patients on this. So again, it's something that people talk about and some people are doing. We have little data to support clinical benefit at this point. How about those who want to know, well, maybe I could just take coenzyme Q10. That's going to make everything better. So in our 2018 AHA-ACC multi-organization cholesterol guideline that I was privileged to work on, we gave coenzyme Q10 a class 3, no benefit recommendation, either for patients who are on statins to prevent side effects or to treat side effects once patients are on statins. And there's no clear evidence of cardiovascular benefit in patients who take coenzyme Q10. What about everybody comes to my office taking fish oil supplements? I mean, everybody. And there was an interesting meta-analysis done involving almost 80,000 individuals. These were fairly high-risk people. 66% had coronary disease, 28% of prior stroke, 37% diabetes. And the studies in aggregate showed no significant effects on coronary heart disease, risk, stroke, coronary or non-coronary revascularization, or major cardiovascular events. Now, there was a slight signal, perhaps, toward borderline benefit on coronary heart disease death. That was about it. So, again, if you want to take fish oil supplements, it's certainly up to you. There certainly are not overwhelming data indicating that the non-prescription fish oils benefit patients in terms of cardiovascular risk. How about everybody coming in on a multivitamin? Everybody's coming in on a multivitamin. But interestingly, there's a meta-analysis of 18 clinical trials prospective cohort studies of over 2 million participants with 18 million person years of follow-up. Pretty robust numbers here, and showing no cardiovascular benefit. So these are the things that your readers always want to know about, and some of you clearly want to know about. And sorry, but that's the data. That's what you got. Okay, exercise. Regular aerobic exercise does seem to make a difference in terms of cardiovascular disease prevention. We're looking for at least 150 minutes per week of accumulated moderate intensity physical activity, brisk walking, for example, or 75 minutes per week of vigorous intensity physical activity. When you do that, it needs to be divided up. Don't do it all at once. I'd like to divide it up, preferably into most days of the week to get these numbers. Now, there's no absolute number above which you have benefit and below which you don't. So I always tell patients that if you do this, even if you can't meet these numbers, more is better than less, some is better than none. So again, it seems to be a dose response curve. For those who want to lose weight, 200 minutes or more a week is really what's advised. 150 minutes per week is for maintenance and for cardiovascular health promotion. Now, Dr. Goff focused on the social determinants of health, and that's really a big deal because when you talk to a patient and talk to them about the consumption of fresh fruits and vegetables, that's more expensive than eating canned things that they can get at their local Dollar General store. So you have to be sensitive to the patient's social determinants of health, thinking about things like what is their economic status, where do they live, tell people to walk, and if they don't have a safe neighborhood, it's a big problem. Okay? So you have to be sensitive to these issues. What is their education level? What is their social and community context? You have to be aware of these things when you're giving people advice about lifestyle issues, because what seems intuitive to you may not be intuitive to them in their environment. So be sensitive to those issues when you're thinking about what you advise to your readers and also what makes sense for most people. Now, you heard information about the importance of smoking cessation, and clearly we ask every patient at every visit, are you smoking? And if they're smoking, we try to help them to initiate behaviors that will help them to stop. So we strongly advise them to stop smoking, and some people will actually do that when you ask them to do it, but some won't, and more often they won't. But for those who may be interested, there are lots of things that we can do as health professionals to give them greater likelihood of being able to stop. One is to use the nicotine patches, and nicotine patches are available in various doses. And the doses really depend upon how many cigarettes per day the patient smokes, or when the patient starts smoking after they first awaken in the morning. So we will adjust our dosage recommendations to the patient's current habits. Also, nicotine replacement therapy is available as gum, and it's also available as lozenges, depending upon what the patient prefers. Those are all options that patients can use to help them stop smoking. For those who try these and are not able to stop, there are medications that can be used, or medications can be used along with the nicotine patches or gum or lozenges to help patients stop smoking. So bupropion, which is marketed as Zyban, or Wellbutrin SR, 150 milligrams can be started in the way that it says up here. You start out in the lower dose and then move up in the dose. Again, you can use this with the nicotine replacement therapy. Or another one that is commonly used is varenicline, which is Chantix. This also is gradually ramped up. And for the first week that the patient's taking this, they continue smoking. So again, it's something that you can use to help the patient stop smoking in those who are willing to do so. If the patient is not willing to do so, then you continue to ask them at every visit, are you now willing to do so? So it's a continued process of trying to find out when the patient is ready to change his or her behavior. Now, you heard about the importance of high blood pressure treatment from Dr. Goff, and there's no question that This is one of the biggest problems that we deal with in the area of preventive cardiovascular medicine. There was a terrific guideline that was published in 2017 by the American College of Cardiology and the American Heart Association that dealt with some of the key issues in the identification and management of high blood pressure. Now, one of the first and most important points to remember in this guideline is that we used to think of high blood pressure as 140/90 or greater. The guideline now points out that stage 1 hypertension is 130/139 over 80/89. Now, if a person has a blood pressure of 125/89, that's still high blood pressure because one of these numbers is met. But the bottom line is this was considered high blood pressure in the past. Now this is considered high blood pressure according to the 2017 guideline. And when we find a patient's hypertensive, our first approach should be to consider non-pharmacologic interventions that can be done to help their blood pressure to be lowered before we think of the use of medication. And our goal is to lower their blood pressure to less than 130/80. So what are some of these interventions that might be considered non-pharmacologically? Well, first of all, weight loss. Weight loss, simple weight loss, is a way of lowering blood pressure. And those people who manage to lose 10 pounds can oftentimes get 5 millimeters of mercury reduction in their blood pressure. And that should be a great motivation for many people to lose weight, because they'd rather lose weight than not take a medication in many cases. The DASH diet, which is a diet rich in fruits, vegetables, whole grains, low-fat dairy, sounds like exactly what we described before, is associated with 11 millimeter fall in blood pressure. Wow, that's terrific. You add the two of those together, and you've really got something significant. Usually, most blood pressure medicines lower systolic blood pressure in the range of 8 to 10 millimeters of mercury. So you have the equivalent of one blood pressure medicine. So that's great. Reducing your dietary intake of sodium works in some people. Increased potassium intake, fresh fruits and vegetables again, can usually have further blood pressure lowering effects. Physical activity, adding those same exercise habits, you get another 5 to 8 millimeters of mercury systolic blood pressure reduction. And reducing alcohol intake to no more than 2 drinks daily for men or 1 drink daily for women can give you another few millimeters of mercury. Add all that together, and you've got the impact of several blood pressure medicines. So I have some patients who don't want to make any changes, and we do the best we can under those circumstances, and we add as many medicines as we need. But I have some who really don't want the idea of taking medications and are willing to do at least some of these to mitigate the need for more blood pressure medication. So all of this is worthwhile and important information for your readers to know about. Now, I'm going to bring this up because I think this is a really important issue, and that is the blood pressure guideline talks about how important it is to properly measure blood pressure. And this is an issue that is often skirted in medical office visits, largely because people are in a hurry. But I'm going to talk about this because I want you to be aware of it, because it makes a huge difference in terms of treating patients. This particular cartoon shows the nurse with a blood pressure cuff around his neck, and actually reflects the fact that so often during medical visits, blood pressure is not properly measured. So let's talk a little bit about it. Isn't this a really nice thing to see? We've got a nice looking doctor talking to a nice looking patient, and they're having a great conversation. But interestingly, you'll notice that her sleeve is kind of halfway up her arm. They're engaged in a conversation, and lo and behold, that may raise the measured blood pressure by 10 millimeters of mercury. How about this one? You're sitting up on the table and someone puts a blood pressure cuff on your arm. That's not how to check blood pressure. Your blood pressure should be measured with your arm at the level of your heart, seated in a hardback chair. And in fact, this can raise your blood pressure 6 to 10 millimeters of mercury. How about this one? Has anybody ever been into your doctor's office and they do blood pressure measurement on your clothed arm? I'm sure that's never happened to anyone in this office. Yeah. Well, guess what? That can raise blood pressure 5 to 50 millimeters of mercury. So now we're talking about blood pressure medicines and treatments and having to come back to your doctor's office and checking your blood. And wait a minute. All this might have been due to the fact your blood pressure was not properly measured. So this is the way you do it. And believe me, it can be done in a medical visit. Relax for at least 5 minutes. Use the correct sized cuff, and we'll talk about that in a second. Put the cuff on a bare arm. The arm should be at the level of the heart. Legs should be uncrossed. Back supported by a chair with feet flat on the floor. No coffee or alcohol within 30 minutes of the blood pressure measurement. If the patient's got a full bladder, that can raise blood pressure, by the way. And don't talk to the patient. So it's 5 minutes of rest. You say, well, how can they possibly do that during a busy office visit? Well, the answer is, if you're considering an intervention that's, or if you're considering a disease process that's important as hypertension, you better do it right. You better do it right. Because this is what makes a difference. And this is how treatment decisions about whether a person is hypertensive or not should be made. And during the first visit, by the way, blood pressure should be measured in both arms if it's at all elevated, because there may be a difference in blood pressure from one arm to the other. So all this is key in taking proper care of your patients. By the way, you know that a good doctor's office should also have different sized blood pressure cuffs. Because if you have a fat arm, if you have a patient with a very fat arm, using that blood pressure cuff down below, which is the so-called usual adult blood pressure cuff, can magnify blood pressure. It can cause a high blood pressure reading in a person whose blood pressure is not elevated. That patient with a fat arm should use the large adult cuff. So again, is the blood pressure measured properly? Think about all this stuff. I mean, it's very important, but this is what people need to know. And so we recommend that the right size cuff be used, but also the cuff, the arm should be out here. But you have patients all the time who talk about using wrist blood pressure cuffs. They're not nearly as accurate as arm blood pressure cuffs. So discourage the use of wrist blood pressure cuffs in those patients who are following their blood pressures at home. And that brings us to the issue of home blood pressure. Important to recognize that in-office readings often do not reflect home readings. And people are home most of the time. They're not in your office most of the time. So we use the office readings to establish the diagnosis of hypertension and to give us some idea of how well the patient's doing. But in truth, what we really want to find out is, how is their blood pressure at home? Because their blood pressure at home more accurately reflects what their blood pressure is during their normal daily lives. And so when we teach people about home blood pressure monitoring, we give them instructions. We say, by the way, when you check your blood pressure at home, 5 minutes of rest in a quiet room with your arm at the level of your heart, seated in a hardback chair with your feet flat on the floor, with no coffee or alcohol within 30 minutes of your reading. Morning readings tend to be the highest, so first thing in the morning is a good time to measure blood pressure. Check it periodically throughout the day if there's concern. If it's still elevated under those circumstances, if it's greater than 130 systolic or if it's greater than 80 diastolic, with or without medicines, you need to have further adjustments. So your home readings really act hand in hand with your office readings to help you to know what you should do to help that patient reduce their cardiovascular risk. There's also what's called ambulatory blood pressure monitoring. Sometimes you get a high reading in the office and the person says, my blood pressure at home is normal, and there's debate, you're not quite sure. So ambulatory blood pressure monitoring, where they actually have a gadget that's hooked up to them like this so that its blood pressure is measured multiple times throughout a 24-hour period of time, that gives the patient information and give the doctor information on what their blood pressures really are throughout the day. And there are certain standards that are used for correlating office blood pressure with home measured blood pressure with ambulatory blood pressure monitoring to help the physician to know what should be done to maximally reduce the patient's cardiovascular risk. And so once we have this information, then we can consider appropriate treatments. If the patient has blood pressure less than 130 over 80, but if it's in the 120 to 129 over less than 80 range, we might say, well, still, those dietary and exercise interventions make a lot of sense, although we do not traditionally use medication under those circumstances. And we reassess their blood pressure in 3 to 6 months. Now, if the patient's got a blood pressure of 130 to 139 over 80 to 89, we then use that risk calculator and get an idea of what is their 10-year ASCVD risk. If it's 10% or greater, according to the risk calculator, we may consider non-pharmacologic therapy if their 10-year risk is less than 10%. But if their risk is 10% or greater, we will traditionally do non-pharmacologic therapy and blood pressure lowering medication. And again, it really depends upon the patient's situation. Certainly if they have atherosclerotic cardiovascular disease, they've had an MI, they have peripheral arterial disease, they've had a stroke, you definitely want their systolic blood pressure less than 130. If they have diabetes, you want their systolic blood pressure less than 130, and you're inclined under those circumstances, those higher risk patients, to use medication in addition to lifestyle treatments. So again, treatment should depend on the patient's cardiovascular risk. Now let's get to cholesterol a little bit. I had the privilege of serving on this writing group, and we have tried to simplify things to help clinicians to know when it's appropriate to consider lifestyle therapy only and when one should consider, in addition, the use of cardioprotective medications like statins. And so in primary prevention, by the way, primary prevention means trying to prevent the first event from occurring, versus secondary prevention, which means the person's already had a heart attack or a stroke or has required a stent or a bypass. That's secondary prevention. So primary prevention, first step is risk calculation. And you basically go into several different levels of risk. A low-risk person, that risk calculator comes up less than 5%, in which case lifestyle therapy alone, diet and exercise, makes a lot of sense. If the 10-year risk comes up 5 to 7.4%, or 7.5 to 19.9%, we look at other factors called risk-enhancing factors, or in some cases considered coronary calcium scoring, to help us to make a decision with the patient about what therapy is warranted for prevention. Those who have a 10-year risk of 20% or greater, no question, they benefit from both lifestyle therapy and statins. So let's talk for a second about this intermediate group. And when you fall into that 5% to 19.9% 10-year risk, the question is, how do you make that decision about whether you should think about a statin or whether you really should just consider lifestyle therapy? If the patient has any of these factors, they've got a family history of early heart disease, they've got an LDL cholesterol of 160 or greater, they've got metabolic syndrome, people who have who walk into the room stomach first, people who have high blood pressure, diabetes, or elevated blood sugar, low HDL cholesterol, high triglycerides, chronic kidney disease, early menopause or preeclampsia, chronic inflammatory disorders, South Asian patients in particular who are at increased risk. These patients then, if they have a 7.5% 10-year risk or greater, tend to benefit from statin therapy. When you're still not sure, the guideline says, then consider coronary calcium scoring. Are you all familiar with coronary calcium scoring? It's a 10-minute test. No IV is involved, no contrast. It's a very rapid CT scan of the heart. You receive less radiation than a mammogram, 1 millisievert of radiation. And it gives profoundly important information in people between the ages of 40 and 75 about their future cardiovascular risk. Because if you don't have any of these white calcium deposits in the artery walls, it doesn't look for blocked arteries, it looks for calcium deposits in the walls of the arteries, and that occurs before you get blockages. Those who have a certain amount of this calcium turn out to be at increased risk for future heart attack. And as a result, we use that to help us to determine whether a person should benefit from being started on a cardioprotective medicine like a statin. Interestingly, if you have no calcium, your 10-year risk for heart attack is very, very low, very low. And as a result, many of those individuals can then be treated with lifestyle therapy alone for prevention rather than the need for statins. So this is a really nice way to determine who's at risk and who's not at risk. Now, in many places around the country, you can get coronary calcium scores for less than $100, usually $99. It is not an insurance-covered test at this time, although there are many places that are now moving toward covering coronary calcium scoring under selected circumstances. But in fact, when the decision is uncertain about whether a person should be started on a statin, or if the patient's not sure if they want to, and the doctor's saying, well, maybe you should, and I don't know, coronary calcium scoring is the best tiebreaker there is. So again, it's something that we are emphasizing more and more, and our guideline is emphasized more and more as a reasonable way to provide additional decision-making information for the patient-clinician risk discussion. Now, secondary prevention, that is people who've already had heart attacks or strokes or carotid surgery or peripheral arterial disease, the highest intensity statin that can be used should be used, because the higher the intensity, the greater the risk prevention. If you can't use the highest intensity, use a lower intensity, but use the most that you can. And when the LDL cholesterol is, there's a typo there, it should be 70 milligrams per deciliter. One should consider the addition of a non-statin, such as ezetimibe, which is a cholesterol absorption inhibitor, or PCSK9 inhibitor, which is the injectable cholesterol lowering treatment, to further help lower cardiovascular risk. A few points to remember about statins, because people always want to know about them, because so many people are taking them. Should be considered in patients who have a 10-year risk of 7.5% or greater. The benefits are proportional to the starting level of LDL cholesterol. Those who have the highest levels tend to have the greatest protection from statins, and those who have the highest level of risk tend to have the greatest protection. The higher intensity or higher dose statins provide the greatest protection. And muscle symptoms, which sometimes are symmetrical areas of either mild discomfort or on occasion weakness, may occur in about 6 or 7% of patients taking these medications. They're generally very readily handled by adjusting the dose or choosing a different statin. You can usually get around that very nicely. There is a slight statistical increased risk for diabetes in patients taking statins, but in fact, if a person were to develop diabetes, the treatment of choice is a statin, because diabetics die from cardiovascular disease. So that's a non-issue. And then it should always be present for add-on therapy. When you're considering adding a second drug, you always like to have the statin as a baseline. So these are the key points about statins. And I mentioned ezetimibe. It's a generic, once-a-day, easily tolerated pill, especially useful for older diabetic patients when the LDL cholesterol is persistently greater than 70. Occasionally used bile acid sequestrants, although they're often associated with gastrointestinal side effects, and they're not widely used because there are inconvenient dosing forms, but they're sometimes used in those with very severe cholesterol elevations where you need additional LDL lowering. And then there are the PCSK9 inhibitors, which are the newest additive, well, I shouldn't say the newest, they're one of the most recent types of add-on therapy, which are injectable. They're given every 2 weeks generally, and they're very well tolerated. They're quite expensive, so their use should be limited only to those patients who are very high risk for atherosclerotic disease. Those who've had established ASCVD and have multiple additional risk factors, or those who've had multiple ASCVD events. Icosapent ethyl, which is a prescription type of fish oil that There was recently a very important study that was published showing that when you give people with established ASCVD or diabetes and multiple risk factor icosapent ethyl, that is 2 capsules twice daily, in addition to maximally tolerated statin, and follow those patients out over a period of 5 years, there's significant reduction in cardiovascular risk. So this is a new approach to further reduce cardiovascular risk. It's been endorsed by multiple organizations, including the National Lipid Association, the American Diabetes Association, and the European Atherosclerosis Society, and the European Society of Cardiology. So these references would give you more information if you are interested. On the horizon in the lipid field, bempedoic acid. You're going to be hearing about this. This is a drug which seems to be able to be used in patients, even those who have difficulties with statins. It's 1 pill a day. Lowers LDL cholesterol by 15 to 20%. Seems to be well tolerated, although it does increase uric acid, so it would therefore have to be used in patients, used with caution in patients with a history of gout. This is still not on the market, but it's moving closer to approval. Inclisiran, which is another type of PCSK9 inhibitor, but is much longer lasting than the ones that are currently on the market. Lowers LDL cholesterol by at least 50%, well tolerated. Generally, an injection is given at baseline at 3 months, and then it can be given every 6 months thereafter. So instead of having to use injections every 2 weeks, the opportunity would be to give patients just a few injections, 2 injections a year over time, that will help to maintain their LDL cholesterol level at 50% lower than baseline, which kind of takes the adherence issue out of the picture, which is kind of nice. People don't have to remember to take their pills all the time. If they get 2 injections a year, their cholesterol is fixed for the year. And then there's another agent called ApoA-LRX, which is injectable. It lowers this particular type of LDL particle called lipoprotein A by up to 80%. And that's of interest because this is a proatherosclerotic, prothrombotic particle that some people have floating around in their circulation. Elevated levels are found in 20% of the population. It's associated with increased risk. It's not measured on a routine lipid panel, so any of your family members or readers who have had atherosclerotic events, they said, gee, my cholesterol is fine, my blood pressure is fine, I don't know. And by the way, I have other family members with early heart disease. Lipoprotein A should be measured, simple blood test to check it. This treatment lowers it by up to 80%. Statins don't affect it, exercise doesn't affect it, diet doesn't affect it. So they're looking at ways to lower this and then to find out if such lowering will reduce cardiovascular risk. So this is a ways off, but there are important and major large clinical studies being looked at right now to determine if this reduces cardiovascular risk. Now, with regard to type 2 diabetes, and for time, I'm not going to go into all the details of type 2 diabetes, except to say that there are a couple of agents called the SGLT2 inhibitors or the GLP-1 receptor agonists that are used in diabetic patients after they have been put on a diet and metformin that have been shown to reduce major adverse cardiovascular events and reduce heart failure. And also, both of these categories have been shown to reduce progression of chronic kidney disease, which is another big problem in diabetic patients. So there are treatments now that lower blood glucose, but also have cardioprotective effects in the treatment of diabetes. And then aspirin, there are a lot of patients coming on aspirin wondering if I should be taking aspirin. And I can tell you that the answer is becoming quite clear. There was a study looking at the effect of aspirin on all-cause mortality in healthy elderly patients, typical of the older populations that we see. This was a group of almost 20,000 patients, followed up over almost 5 years. And what was seen is that the likelihood of major hemorrhage was increased in those taking aspirin, and the benefits on cardiovascular disease and primary prevention were no different than placebo. And so the bottom line here is the use of low-dose aspirin as a primary prevention strategy in older adults, that is, adults 70 years of age or older, resulted in a significantly higher risk of major hemorrhage, did not result in a significantly lower risk of cardiovascular disease than placebo. So those who are 70 years of age who haven't had events probably shouldn't be taking aspirin in general. So how about aspirin for diabetics? So they did a study looking at over 15,000 patients who were followed for 7.4 years, a fairly similar population to what we saw in the previous study, showing that there was perhaps a slight reduction in the first vascular event in these patients. But on the other hand, major bleeding occurred much more frequently in these individuals. So the bottom line, again, was it prevented, to a slight degree, serious vascular events in people with diabetes and no evident cardiovascular disease, but it did it at the risk of causing more major bleeding. So the bottom line was the absolute benefits were largely counterbalanced by bleeding risk. And then finally, in people in that intermediate risk group that we talked about before, that group where you're not quite sure whether they should receive aspirin prevention or not, this study looked at that group. Over 12,000 patients followed for 5 years, and the results were the same. Just does not seem to show benefit in primary prevention. Maybe the only time you'd think about it would be if you had a patient with a very high coronary calcium score, with a strong family history of early heart disease. Maybe you'd give that patient a low-dose aspirin. But aside from that, pretty much stay away from aspirin for primary prevention. On the other hand, when you've got a person who has established vascular disease, then that's when you want to use aspirin, because there's clear evidence that those patients who have had heart attacks, who have stents, who've had bypass, who have peripheral arterial disease, who have carotid disease, they benefit from being on aspirin. And those who can't take aspirin, there's a drug called clopidogrel, which can be used in those who are unable to take aspirin. Finally, and the last slide I want to show you is, can you teach an old dog new tricks? Well, there's actually a drug called colchicine that has been used for years in treatment who have acute attacks of gout. It's an anti-inflammatory drug, so it's a generic anti-inflammatory drug. And they did a study looking at a group of 4,745 patients who were 1 month out from an MI. And they treated half of them with colchicine, 1 pill a day. And that's not the usual dose you treat people with gout for. Usually give it twice a day for people who have gout. But it's 1 pill a day on top of usual medical therapy, or placebo, 1 pill a day on top of usual medical therapy. And they followed these patients out. And lo and behold, the colchicine group had a significant reduction in major adverse cardiovascular events when they were followed over a period of 2.7 years. So a drug that in the past had been used for gout, but has anti-inflammatory properties, may reduce the risk of future MI in people who have had a previous myocardial infarction. So to summarize, the first step is risk assessment. How high risk is that patient? Secondly, counseling on diet and exercise is indicated regardless of the risk level. You want your patients to adopt heart-healthy dietary habits. Third, decisions on the initiation of drug therapy are dependent on shared decision-making based on risk assessment and based on patient factors with careful consideration of social determinants of health. And finally, the key to successful prevention is establishment of a positive clinician-patient relationship where they understand that you're in their corner and you're willing to understand what makes them tick, that you respect their decisions, but that you could provide them information that will enable them to make reasonable decisions that in their current life habits seem to make sense. So those are my comments, and I'll be glad to address any questions.
Okay, we have plenty of time for questions. We have lots of questions, so I think try to keep them fairly short, but we will go with Amanda, Sonia, keep your hands up. Okay, Amanda, Sonia, okay, Phil, Stephen, Emily, Sandy, Katya, and Jacqueline. So we only have 15 minutes. Maybe we'll push a couple extra minutes, but try to limit to one question.
You're the second person we've heard already who's brought up the improper taking of blood pressure. Do you know, have there been any surveys done or any studies about how frequent it is or how common it is for medical professionals to not take it properly? Has there been research on it?
I don't know of any studies that have addressed that specific question, but I think that the reason that the hypertension guideline brought that up so strongly was because it's frequently or most often not measured properly in practitioners' offices. And I think a lot of that is related to the fact that there is so much time pressure for practitioners to see their patients in defined periods of time. And if you think of 5 minutes of a 15 or 20-minute visit, it's tough, but it can be done if you're committed to doing it, since you realize that hypertension is the most common thing that kills people and gives them cardiovascular events and kidney failure. So I think it's an extremely important issue.
Let's go back to Sonia and then back to Bex.
Thank you so much. In addition to covering health, my mom's a type 2 diabetic who has high cholesterol and basically heart disease, so I was furiously writing notes. I get a lot of questions from viewers and also from my mom about the side effects of all of these medicines interacting, and so I'm wondering, obviously I'm not equipped to handle their questions, but I don't even know that what's being done on the physician level to help them answer questions, because I feel like a lot of these patients keep, as you alluded to, going back, and then it's kind of a game of trial and error for a lot of them.
Well, I hope it's not too much trial and error. Actually, it's very clear that a person with diabetes and established cardiovascular disease needs to be on an aspirin. Usually they're on medication for their diabetes that helps initially to lower blood sugar. Most of those patients turn out to be hypertensive and oftentimes need something for their blood pressure. But diabetic patients with established cardiovascular disease should, if at all possible, be on one of those two categories of drugs called the SGLT2 inhibitors or the GLP-1 receptor agonists. These treatments reduce the risk of cardiovascular disease, and they also reduce the risk of chronic kidney disease progressing, which is what kills diabetics. So I see diabetic patients all the time with established atherosclerotic vascular disease not taking these medications, and I try to let them know that this is extremely important, if at all possible, for them to be on these medications. Now, we're often confronted with issues of polypharmacy, and where we see people coming in with bags and buckets of medicines, and sometimes it's a question of what can I take, what can I remember to take, I need to eat, I need to pay my bills. And so what we have to do is make every effort to prescribe generic medications whenever we can, and then to try to somehow prioritize which treatments are likely to give them the greatest benefits. Certainly, for example, aspirin is a minimal expense. Generic statins, even potent generic statins, are extremely inexpensive now, so you can get those. Blood pressure medications, all of the first-line blood pressure medicines are generic. So you can pack a tremendous punch into that without costing the patient very much. Now, the diabetes medicines, metformin is generic, but the SGLT2 inhibitors and the GLP-1 receptor agonists are currently brand name, but because of the beneficial cardiovascular effects, many more insurance companies are covering those medications and helping patients to get onto proper medical therapies to prevent risk.
Okay.
Hi, thank you for your talk. I have a book on my shelf called Big Fat Surprise by Nina Techholz. I don't know if you've seen that. It's one of a number of books about higher fat eating, and it's influenced the way I eat. And I just wondered, what is the best evidence that people shouldn't eat full-fat dairy products and should eat the non-fat ones?
So we run into the difficulty that so many of the studies have not, it's not like you've put a patient on a drug. People live in the real world, and it makes it very difficult in so many ways to assess food components and their individual food components, because people eat a variety of food components and their associated cardiovascular risk. But experts in the field of medical nutrition have shown with pretty good, I think very good information that in fact, saturated fat, so the fat that's found in meat products, whole milk or 2% or higher dairy products, hard cheeses, butter, ice cream, those are the kinds of fats that tend to raise blood cholesterol levels. In addition, there is reasonably good evidence now to indicate that eating cholesterol itself, like an egg yolk, for example, does increase cardiovascular risk. And there are a lot of studies that support that. And the consensus in the dietitian community, where they look at these regularly and they try to make these decisions, is that reducing the intake of saturated fat and cholesterol does seem to make sense in terms of cardiovascular risk reduction. There are debates about this among some people who are experts in the field, but the general consensus is still that reduction in saturated fat is reasonable, and reduction in cholesterol intake is reasonable. Vegetable-based fats, the monounsaturated fats, canola oil, corn oil, safflower, sunflower oil, olive oil, seems to provide some cardiovascular benefit. And so it's not so much low fat as it is making sure that the fats that you choose to reduce are the saturated fats.
I'm going to take 2 questions real quick. Nutrition, you talk so much about nutrition, but how many doctors are spending 20 minutes with their patients talking about nutrition or even referring to a nutritionist? Secondly, you mentioned the calcium scoring. As you know, the United States Preventive Task Force still does not recommend it. If you're saying do it, I read the United States, this highly, honored task force says don't do it. Why the conflict?
I think their perspective is
there's not enough information.
Their perspective, and they have a very high bar that they use for recommending a specific intervention. Our guidelines did recommend it in selected individuals, particularly those intermediate risk individuals. You want to know why it's important in those people, those with a risk between 5 and 19.9%? The reason that's important is because it turns out 50% of those people with a 10-year risk between 5 and 19.9% have calcium scores of 0. 50% have calcium scores of 0. You can take a bunch of people with exactly the same numbers of risk factors. Half of them are going to have calcium scores of 0. Half of them will have calcium scores that are high. And as a result, if you want to treat a patient with a calcium score of 0 with a statin, you probably have to treat a couple of hundred people to prevent one event. Whereas those who have calcium scores of 100 or above, the numbers are roughly 50 to prevent one event, which is considered to be a clinically important intervention. So, and by the way, if you choose to treat someone with a calcium score of 0 with a statin, they have to be buying medication. They have to be going back to their healthcare provider for follow-up. They have to take time off work. They have to have lab tests, all that for something that's very unlikely to provide them benefit. So that's why calcium scoring is so important. So there's this gray area sometimes that falls between what the U.S. Public Safety Preventive Services Task Force recommends and what really, there are newer data, and sometimes you have to connect the dots. And I know that's difficult sometimes, but our 2018 ACC-AHA cholesterol guideline actually did recommend calcium scoring, particularly in that intermediate risk 5 to 19.9% group, as a reasonable test to do to help to identify which patients are likely to benefit from these types of therapies. So that was on the calcium score. Your other question was?
How often are your doctors here recommending people meet with a nutritionist?
Oh,
you speak so much about
so the problem is that medical nutrition therapy is generally covered for those who have obesity, type 2 diabetes, or chronic kidney disease. For reasons that are unclear to us, it's not insurance covered by people who have atherosclerotic vascular disease. It's not covered by people who have hypercholesterolemia. It's just the way the United States health system works at this time. And in fact, if better counseling could be provided for many patients, I think that there would be much greater options for people who might not want to take medications, who may be able to get their numbers improved without the use of medication. And we need to improve nutrition education in medical schools.
Well, a lot of data shows even diabetics don't get it.
Right. Yeah.
People say diabetics aren't getting it. Why expand?
But diabetics actually, insurance companies do cover providing nutrition counseling for diabetics. But there aren't that many dietitians around either. So that's why everybody in the healthcare field who can needs to get as much information as possible about current evidence-based treatments that reduce risk and provide that for their patients using whatever tools they can.
Great talk, doctor. I have a comment and a quick question.
Sure.
So for reasons I won't get into, I had a coronary calcium score and I was 172. And my brother and sister then went to get theirs. They were both zeros. Same genetic background. I'm on a statin and other things, and my brother and sister are on lifestyle modification.
Great.
The risk calculator, is that on my iPhone?
Yeah, the risk calculator you could get by going to acc.org. You can find it. You can get it in multiple different places. At Google risk calculator, you can download it either onto your smartphone, or you can download it onto your laptop.
Thank you. Okay. So we have Sandy, Katja, Emily H, and Jack.
You can skip me. She asked my question already.
Okay.
Oh. Good, then I'll take hers because I have two. One, sir, you talked about early on that studies don't show the benefits of fish oil, and yet later on you indicated that there was a specific type of marine oil, fish oil, that does. One, can you explain the two pieces of that? And then the other thing I wanted to go back to was your slide on keto, because I have written about that recently, and one of the claims that the folks are making that are on, I read the lipid study, there's a difference between fluffy and unfluffy cholesterol.
Okay, so I'll be happy to deal with both of those.
Thank you.
So the first thing. Well, you want me to deal with the fluffy versus non-fluffy first, or do you want
fluffy?
Okay. So fluffy versus. Okay. So there have been studies that have looked at different particle sizes of the LDL cholesterol, and there used to be studies years ago suggesting that larger particles were good and smaller particles were bad in terms of cardiovascular risk. However, studies that subsequently followed showed that it's not the size of the particles, it's the number of particles you have. And if the large particles were so good, why is it that patients with familial hypercholesterolemia, the worst type of severe hypercholesterolemia, have only large particles? It's not the size of the particles, it's the number of particles, whether they're small or large, that makes the difference. So those particular people who claim that they were real concerned about changing particle size,
They're looking at old studies.
they're looking at old studies.
Okay.
Now, your other question was about?
Was about the marine oil.
Okay. The earlier studies I talked about were using non-prescription medicine, non-prescription fish oils that people can buy in the health food store or their pharmacy. The study that showed strong cardiovascular benefit was a pharmaceutical grade, highly concentrated icosapent ethyl EPA only fish oil, which is not available non-commercially. So this is a different type of a fish oil preparation that is highly purified and FDA approved. So,
why wouldn't we all be on that?
Well, it's an interesting question. This particular study showed that this fish oil protected people with established atherosclerotic cardiovascular disease or type 2 diabetes and 2 or more risk factors, but they had to have triglycerides that were 150 milligrams per deciliter or higher. Now, that's not very high, but that's what they had. 150 milligrams to 499 were the triglyceride criteria in that study. And the other fish oil studies that have been done with the over-the-counter non-prescription fish oils did not specify triglyceride levels. So it seems that if you treat people with triglyceride levels of 150 or greater with prescription fish oil, specifically icosapent ethyl, or brand name is Vascepa, that does reduce risk, and it does so in a very vigorous way. So you can't go out to GNC and expect that you're going to get the benefit that you would get if you receive this prescription type of fish oil.
Okay, Katja, and then Emily H, and then that would be last question.
Okay.
In your experience, what are the benefits of wearables, those smart technologies for prevention? You know, people basically constantly monitoring their own blood pressure, heart rate, etc.
Well, the wearables are impacting multiple different areas. They're looking at Things like, how many steps a day do you take? Are you, certain of the wearables measure blood pressure, certain of the wearables measure heart rhythm. And they're even going into many other areas. The answer is those who generally use the wearables are those who are generally more concerned about their health anyway, which means that would be associated with other health-related behaviors. They'd probably be going to their healthcare providers more often. They would probably be following other health-related behaviors. So it gets very difficult to determine how much the wearables affect health because they're doing certain other things that would alter their health. It's another option that people may want to consider, and some people it acts as a motivator, but it's hard to say how much benefit they provide.
And Emily, can we guess what your question is?
It's not about that. On smoking cessation, just from searching around, it seems like it's generally accepted that like a really good program will help 20 to 40% of people quit for a year, which seems really low. I have a family member who's done literally all of the things that you listed for cessation. Are there any emerging or new methods, or what do you see providers recommending for people who feel like they've done everything?
Well, here's something interesting. There was a study that was published in the Journal of the American College of Cardiology at the end of 2019, looking at smoking versus vaping, the same amount of nicotine, and they actually figured out a way to measure the amount of nicotine that was in their cigarettes versus vaping. And they seem to suggest that endothelial function, which was measured by there's a tool to look at how arteries respond to various interventions, their stretch, et cetera. Brachial artery reactivity was actually less in those who vaped than those who smoked. So it may be a harms mitigation approach, by not suggesting that you use THC in your vape, but it may be a harms mitigation approach if you can actually get an idea of how much nicotine the person inhales with cigarette smoke versus vaping, to use vaping instead of cigarette smoking. So, but aside from that, I can't tell you anything else more information I could give you aside from the nicotine replacement therapy and pills that I suggested in the
Right. Are there other health concerns with vaping, though, that people would be worried about?
I mean, all the health concerns that were mentioned by Dr. Goff, I mean, lung injury in particular is a real concern. And, again, it's such a new habit that we have little information about the long-term impact of this. So I would not suggest it to anybody. But those who are just inveterate smokers who just can't think of anything else to do, it may be a harms mitigation approach that might be considered by some providers. I'm not prepared to make that recommendation myself, however, at this time.